Good morning, everyone, and thanks for joining us today, and thanks to the previous panel for sharing some really good information about sort of the fundamentals of the IRA and what that looks like from an implementation standpoint. So at the PAN Foundation, you know, we have long believed there needed to be an out-of-pocket cap, like many of you in this room. And our advocacy and engagement team has been advocating for that for a series of years. And because of that, we have really tried to pay very close attention to what that impact could potentially be. Several years ago, we commissioned an internal study with actuaries to look at what out-of-pocket costs could do, out-of-pocket cap would do, and try to understand that in a really meaningful way. So when this legislation passed, there were immediate actions inside the organization to say, okay, let's update this right away. But then we started hearing from patients, and our patients were like, what does this really mean for us? So we immediately turned our attention to Avalier, who has been a great partner to PAN throughout the years, and I know a partner to many people in this room as well from the manufacturer side, to really understand what that means. So I'm happy today to be joined by two stellar people on this diverse panel, diverse in thought and perspective, because we sort of have the analytical side that we're going to share with you today, but we also have the real human-centered patient experience that you're going to hear from today with George. So I'm just going to pause for a moment and let the two of them introduce themselves, and then we'll get kicked off.
Great, I'll go first. I'm George Valentine. I'm an actual patient. In 2002, I was diagnosed with chronic lymphocytic leukemia, and I've been in treatment for that for the last 21 years. And I hope to just spend a few minutes sharing that experience with you, as well as my view of what the Inflation Reduction Act will mean to me personally.
And I'm Kelly Brantley. I lead Avalier Health's policy team. We are based in DC and a consulting services firm that has been partnering with organizations like PAN and others to really dive into policy and figure out what it means for people's businesses, what their organizations need to know, and really I tend to think about what it means for the patient and consumer in the end of the day.
Well, and we're happy to have both of them here, and I realized I didn't really introduce myself. So I'm Kevin Hagan, the President and CEO of the PAN Foundation. So what we wanted to share with you is a little bit about the key Medicare Part D reform. So we just, you heard a little bit yesterday. If you heard Corey's conversation in the morning, the panel before us just gave you an excellent overview of that. So what we did not want to do is sort of deep dive and rehash any of that. But I think a couple of things we did want to sort of set framework around is this concept, and you heard it on the previous panel, that before reform happened with the IRA, people with Medicare were the only insured group without an annual cap on their out-of-pocket costs, which is quite burdensome for them, particularly those that were on specialty medications. So after this reform has passed, and in 2025, we know that that cap will be at $2,000. You also heard the previous panel talk briefly about smoothing. You know, I am really proud, although I've only been the CEO of the PAN Foundation for a little over a year now, I am really proud of the work that our advocacy team has done under the leadership of Amy Niles, because way back in 2014, we hosted a PAN challenge around patient affordability and solicited papers on what could be interesting ideas around solutions that would create patient affordability. And Dr. Jalpa Doshi at the University of Pennsylvania presented a paper that won the PAN Challenge, which talked about this whole concept of smoothing. And since 2014 or 15, I know advocacy groups like ours around the country have sort of banded together to make sure that this provision was included in this IRA. And I think what you'll see is there are many challenges that still face in terms of implementation, but this is a real opportunity for our patient population to have that ability to sort of smooth out those payments and plan for it in a more financially astute fashion over the course of the year. So with that, there we go. We wanted to get to how will these reforms really impact patients? So as I shared with you, as the reform was passed in 2022, we immediately began fielding questions from our patients and really understood that this was going to be a confusing time for them. We went out to understand this in a greater way ourselves. Like I said, we did some polling in October of 2022 that I'm going to share with you shortly. But we also wanted to go to people who have deep expertise in this, and we did turn to our friends at Avalere and commissioned a study on what this really meant in terms of patient need. So we're going to turn this over to Kelly now, and she's going to spend a little bit of time walking through the analysis that was done. And then we're going to talk a little bit about the poll that we conducted on the PAN side of our of Medicare beneficiaries, and then really the impact on the patient. So,
Great.
Kelly?
Thank you. So as Kevin said, we did some work with the PAN Foundation, and he says as soon as the law was passed, I actually remember getting a phone call before the law was passed. Like as it was rolling out, we were like, oh, this is really happening. And we started the conversation of what is this going to look like even in the best of circumstances. So that was our aim here, to look at, if perfectly implemented, what would happen to patients, what would their out-of-pocket cost experience be in the new world of Part D. We heard a panel just before this about what the out-of-pocket experience was like before the IRA, and certainly many of you have experienced that either personally or through the consumers who come to you for assistance. And this was really looking at how do we project what's going to happen in the real world when we think about smoothing, when we think about out-of-pocket costs, and that those expenses really over the course of the year for a lot of patients. And so these are some top 2 highlights of findings that we have from our analysis. The first is that if you look at 2025, how many people are going to reach a $2,000 out-of-pocket cap, and that is 2.6 million individuals. That's a lot of people. It's not everyone, though, but it's still a lot of people. Remember, there's, 55 million individuals in the Part D program, maybe more at this point. So we're not talking about a huge proportion of individuals, but we are talking about people with substantial and high health cost needs. And then if you also think about what proportion of people who are going to hit an out-of-pocket cap in 2024 and in 2025, and those individuals whose income is such that that amount is 10% or more of their annual income, it's also a lot of people. 800,000 individuals in 2024 and 200,000 in 2025. That out-of-pocket capped amount is still more than 10% of their annual income. Really, thinking about the question that you asked earlier, this is still a lot of individuals with high healthcare needs and high healthcare costs compared to their annual income. The panel right before was talking about low-income subsidy. 150% of the federal poverty level is very low. That is not high annual income. And so folks at 155% or 200%, that is still low income by almost anyone's stretch of the definition of low income. And so that's how we get to a place where people are spending a capped amount of $2,000 and it's still being in excess of 10% of their annual income. So let's move to the next slide. There's a lot of data here. You don't need to know all of the details of this, but in essence, what we looked at is who reaches that out-of-pocket cap in 2024 and 2025, and in which month do they reach it? And so you see that bolus of individuals in January in both years, 2024 and 2025, reaching that out-of-pocket cap that first month, and that's because there's still a deductible and there are still high out-of-pocket costs for people. And these are not smoothed, by the way. These are if individuals walk through the plan year as normal, if you will. And we see in 2024, 1.5 million individuals who will reach that cap, and that cap again is set at catastrophic in 2024. And in 2025, we've got the 2.6 million individuals who reach it. That the percentage on the top of the bar is the proportion of that 100% who are reaching in each month. Let's move to the next slide. We also considered who are these patients, right? What sorts of drugs are they taking? So for folks who are going to reach the out-of-pocket cap in both 2024 and in 2025, what therapeutic areas are the drugs that they take? So top on the list was diabetes drugs. I will make a point out the footnote here because it's critical, is that there is another element of the IRA that caps out-of-pocket cost sharing for certain diabetes meds. That was not included in this analysis, which is why you see diabetes at the top of the list here. But importantly, these are folks who are taking asthma COPD drugs, blood thinners, immunology therapies, cancer meds, as we heard in the panel just before this, and even folks who are taking HIV meds. These are the folks we are talking about who will reach the out-of-pocket cap. Critical conditions, critical needs, and often high healthcare costs. We also considered, on the basis of social and demographic data, who are the folks who are going to be reaching out-of-pocket maxes at different points in the year. In this analysis, we looked at, by those social and demographic cues, who is reaching early in the year. So these are folks who would reach the cap in the first 3 months of the plan year, and we're in this slide, we're looking at 2024. So who's gonna have that high burden of cost at the beginning of the year? These are people most benefited by smoothing, although smoothing isn't working yet. So if we look at that first grouping, and I think if you click the clicker, there we go, okay. If we look at on the basis of eligibility, the folks who would reach that out-of-pocket cap in that first 3 months of the year are folks who are eligible for Medicare on the basis of disability. These are folks who are not over 65. These are folks who are under 65. It's about a third of the Medicare population who is eligible for Medicare on that basis of disability, and there's a disproportionate share of them who will have that high out-of-pocket cost early in the plan year. The next, if you click again, by age, again, that correlates quite closely. The under 65 population, 29% of them will have all of their costs at that early part of the plan year. And then if we look at data by race and ethnicity, there's disproportionate percentages of Black and Hispanic beneficiaries who are also going to have those high out-of-pocket costs in the early part of the year. And so when you think about this, I tend to think these are the folks who are who would be most benefited by a smoothing program, most in need of targeted information about smoothing, all of the pros, all of the cons, really to understand how it's going to work for them, and to know that, and I want to recall the earlier slide when you said you have to opt in to smoothing. This is the kind of thing that's not going to automatically happen for people. They're not necessarily going to know it's going to happen. And it's unclear at this point how much CMS is going to talk about it, how much people's plans are going to talk about it, how much advertising is going to talk about it. I hope it's not called smoothing, because nobody's going to enroll in if it's called smoothing. So maybe there will be a real campaign to get people to understand and opt in. But if they don't opt in, these are also the people who will still have high out-of-pocket costs in the early part of the plan year and still be facing the exact scenario that they are at this very moment. And then if we move to the next slide, we also considered who are the folks, and this tees up another question that came up earlier, the folks who move through a plan year, don't have a lot of healthcare expenses or don't have a lot of drug expenses, get to the final quarter of the year and have a big out-of-pocket expense, because as you might imagine, not all your diagnoses happen in January, and sometimes you get a new prescription at the end of the year, and maybe you weren't preparing for it, and maybe that means that you're facing $3,000 in out-of-pocket costs in 2024 or $2,000 in 2025, smack in December or in November. And so a smoothing program that goes over a calendar year doesn't exactly benefit you quite the same when that big expense comes in November or December compared to when it comes in January. So that's, in essence, the high level, oh, thank you very much. So we also, just to point out a couple of key details here, thank you, Kevin, for cueing me on that. Folks who are eligible on the basis of ESRD diagnosis have a disproportionate share of being in that end of year pool. When you look at age, this is again the under 65, a little bit between 65 and 75, those are the folks who have that expense at the end of the year. And then really call your attention to the final graphic here when we look at race and ethnicity, that Asian, Black, and Hispanic beneficiaries all have disproportionate shares of having expenses at the end of the year. Again, this is not everyone. These are disproportionate shares of folks. And really, when you think about who to target and in what ways for which types of problems are being solved by which policies within the IRA, these were the data that sort of like told the story to us of who will still need help, even in a world where costs are capped and costs are smoothed, as you know, the advocacy industry has been pushing really hard for the last several years. Thank you.
Thank you so much, Kelly. And one of the things that we've committed to do at PAN is try to keep people informed, our patient population, but also our other constituents, like our donors. We've been fortunate to launch an education hub on our website that hopefully some of you will have the opportunity to go through, where all of this information is sort of kept and maintained and updated as we learn more. Because we do know this is an evolving landscape. And as this landscape evolves, the group that should be at the center of all of our attention for that evolving landscape is really the patient. So in October of last year, after the IRA passed, PAN immediately launched a survey of Medicare participants to try to understand what this $2,000 cap really meant to them. So this national poll, it was an online poll with a sample of a little over 2,000 adults on Medicare, and basically found high level is that many people would still find it very difficult to pay, even this $2,000 out-of-pocket cost. And when you look at this poll specifically around the Medicare population, 75%, 3 out of every 4 adults on Medicare, regardless of their health status, actually said that $2,000 is a lot of money and would make it difficult for them to pay. But then when you look from a health equity lens at minority populations, that number jumped up. So Black adults were 86%, Hispanics were also 86%, and then adults with chronic or rare disease were around 78%, really showing that while this is progress, and this is something I think many of us want and feel is really good for patients, is that there are still financial ramifications for the patient population. And when we started looking at things, we also asked some questions, because we know as a foundation, and you know in this field, that there are many other costs associated with care outside of pharmaceutical costs if you have a chronic or life-threatening disease. So we started asking things, and for current patients who had out-of-pocket costs that were under $2,000 a year, 60% of them reported that they would need to cut back on food if their cost structure was there. And then of people who currently had over $2,000 a year of out-of-pocket costs, 57% of them reported they had already cut back on things like food-related expenses. So it just shows us that this understanding of sort of the whole patient needs to be involved in this conversation. You know, from a policy perspective and a manufacturer perspective and a copay foundation perspective, and across the spectrum of patient assistance, we will often talk about certain components of this, but there's a real holistic view of this patient that we need to take into account as we move forward. And this is the quote from Janice Turner, who is a PAN Foundation grant recipient, and she said, after the reform passed, "I think this is a start, but there are a lot of us out there who are on a fixed income, and $2,000 is too much. Without a PAN grant, I would not be able to afford my expensive drugs in addition to the other medications I take." So as we started thinking about this panel today, we thought, what better way to sort of talk about the real impact on patients rather than to have a patient join us. So as you heard George's introduction a little earlier, he's here to share his story. And George has been, I will tell you, in my short tenure at PAN, a phenomenal advocate for patients. He always raises his hand when we have something that we want him to talk about, or a place we want him to go, or a news outlet we want him to talk about when it comes to the patient perspective. So George, share with us, you know, all of the excitement that exists in this industry around IRA reforms, positive and negative, and how it's going to impact us. What does it really mean for somebody like you?
Great, wonderful. So think of it this way. You've invited me into your home, and you've fed me a delicious dinner, water, can't drink anymore, but anyway, and you've asked me, George, so what's going on with you? So I'm going to take 2 or 3 minutes and tell you about my background. I'm going to take a few minutes and talk about my specific illness and what that's meant. I can't condense 21 years of treatment and stuff into 10 minutes or so we'll be very brief with that. And then we're going to talk about how I see the Inflation Reduction Act, okay? So I was born in North Philadelphia, right? Like a stone's throw from here. And I moved to Texas in 1975. I worked 40 plus years in the information technology arena. I've done everything that you can do in the realm of data processing and computers. I've programmed computers. I've managed divisions of data centers and computer professionals and so forth. So my background as a working professional over the last 40-some years. I retired in January of 2019. So that's kind of my working background, working, paying taxes, doing everything that everyone else does. In 2002, I went in for a routine physical, and the doctor called me back in, and he says, George, you know, you've got something very serious. You've got chronic lymphocytic leukemia. Leukemia is a blood cancer, or cancer of the blood. And I think the easiest way to define leukemia is think of it this way. When the cancer of the blood is impacted, it impacts, in my case, it impacts the white blood cells, which are your infection fighters. It's the things that prevent you from getting colds and flus and other types of cancers and things like that. Well, in my condition with chronic lymphocytic leukemia, basically my body says to any kind of germ out there, come on in, sit down, put your feet up, let me get you a cup of coffee. It just opens my body up to any type of infection or other cancers, and I've experienced many of those over the last 21 years. I've been hospitalized numerous times. I've got 10 different doctors. I take 20 different medications every single day to manage my chronic lymphocytic leukemia. Thank goodness and thank God for the Leukemia Lymphoma Society. I know who you are. There is no cure at this time. So that's kind of my background and my dealings with my illness of chronic lymphocytic leukemia. And I used to, in the beginning, I used to go in and get actual chemotherapy treatments to treat my leukemia. When I was first diagnosed, I was told I had 7 years. That was the expected life cycle, okay? So you go in, you get chemo, they give you something to offset the effects of chemo, and you keep doing that over and over and over again. Every year I hit my out-of-pocket. Every year. I was working commercial insurance. Every year I had the highest plan I could get because every year I hit my out-of-pocket. So this cost goes on for 20 years, okay? So in 2016, my doctor calls me in and he says, hey, we got a pill that you can take. You don't have to come in here every week and get hooked up and get infusion. You don't have to take time off from work and come in to get these things done. You take this pill twice a day and you're good to go. Wonderful. When can we start? Well, George, it's a little expensive. Well, how expensive? I'm quoting now, I think somewhere around about $16,000 at that time. $16,000 a month. I said, what's plan B? What's option B? What's option C? Because I don't have $16,000 a month. So he says, I'll tell you what, why don't you reach out? There are some patient assistance programs. And he gave me a link to PAN. Thank God for PAN, because if it were not for PAN, I would not be here today. If it were not for PAN, my quality of life would go from this to something like this, where every week I'd spend days and weeks in hospitals and getting labs and treatment and all of those things. I still have an abundance of those things going on, but that's the impact of the assistance and help that I got from PAN. They've been a godsend for me, and that's why when they asked me, George, can you speak? I'm here. I'll continue to do that. Let's see. This is my actual summary of my expenses for my drugs for the last 12 months. And I don't know whether you can see that or not, but it says that I have a total drug cost of $179,599 of drug costs, of which $15,596 are mine. I own that, okay? PAN, through PAN's assistance, PAN has helped me with that $15,000. So understand, well, what does that mean, George? Okay, they give you this money, what does it mean to you? Well, I'm not just a pill, I'm a person. So I have a quality of life that I'm trying to achieve. That $15,000 helps me to offset that expense so that I could use the other income that I have for things that everybody else wants to do. By the way, I'm 71 years old, I'm retired, and I'm on Medicare. I'm a Medicare beneficiary. So I'm the model of all the things that we've been talking about here for the last hour or so. But that is my actual out-of-pocket cost. The important thing to remember is that as a patient, we have more than just we're not just a pill. I have insurance premiums. I have Medicare insurance premiums for Plan B, Plan C, Plan D. Those are all, some of them are $2,000 a year or more. In addition to that, my wife's on Medicare, so you can double those numbers. So when you say $2,000, okay, well that brings this number down from here to here, but there's still a whole bucket of expenses that patients, especially patients with chronic illnesses, have. I've been to the doctor in the last 12 months. I think it's 60 plus times in the last 12 months I've been to the doctor. I've left home to go to the doctor for a doctor visit, for labs, for MRIs, PET scans, CAT scans, and so forth. And there's real cost to me, a patient, in doing that. I've had over 150 different laboratory tests. They test my blood for any number of things, and because my body is susceptible to other things, I have a cardiologist, I have 2 dermatologists, I have a kidney doctor, a liver doctor, an endocrinologist, and all of these things are subsets of the fact that my leukemia is not protecting me from all of those other things. Okay. Let's talk about the Inflation Reduction Act. So for years, I too have been pushing for predictable drug costs. So I see the act as a positive. However, I think there's still, I think it's a first step and one of many steps that we need to take to really get to understanding what's going on with the patient. Like I said, I'm not a pill, I'm a person. I'm a father, I'm a grandfather, I'm a husband, I'm an uncle, all of those things that you are, I am those things too. And my goal is not just to take a pill every day. My goal is to sustain a quality of life. That's my goal. That's what the PAN Foundation, covering the cost of the pill, does to me directly, is it allows me to have a quality of life where I don't get up in the morning and worry about staying alive. My outcome is going to be whatever it's going to be. I get up in the morning and talk about where can I spend time with my grandson, Brewer. That's what's important to me. And so that's my story. I think that the Inflation Reduction Act addresses one need, the need of the cost of the pill, and I think that's a good thing. But I think there's a lot of other things in that bucket that need to be addressed. Things like a medical appliance. My doctor says you got atrial fibrillation. You need a watch to check your AFib. You need a watch to check your blood pressure. You need special shoes if you have certain conditions in your feet and cancer in your feet, things like that. Those things all cost money that most people that aren't ill would not have to spend. I'm just one person sharing one story with you. I don't speak for all patients, certainly. But that's my story. I'll be here for the remainder of the day and into tomorrow. So if you have any specific, more detailed questions, you want to know about what it's like to live with leukemia for 21 years, stop me. If you want to see a picture of my grandson, stop me. I'll be glad to show you that too. And I'll turn it back over to Kim.
Well, thank you, George. And I would encourage you to stop him and ask him questions and see that grandbaby because he is adorable. I saw a picture a little earlier today. Brewer, right?
Brewer, yes.
Yep. We've heard Brewer, conversations about Brewer before because that's one of the things that, you know, is really important for me. I mean, I will just be honest and admit that as the CEO of a patient assistance foundation, I don't get a lot of direct contact with patients. You know, that's done in our contact center, and I would guess that the vast majority of people in this room are the same way. You know you're working to help patients. You know that that assistance is critically important, but that personal interaction and understanding of what their challenges are every day is something that I personally find very valuable. It sort of recenters and regrounds me in the work that we have to do as an organization and the work we have to do as a collective industry to make sure that people like George have the life that they deserve and that they want to have. And I think that really brings us to the question of the day, which is, okay, with all of these reforms, what does it really mean? Is there still a continued need for patient assistance? And I hope what you can take away today is the answer is yes. The answer is yes for multiple reasons. The answer is yes because this act did not solve all the problems. The answer is yes because people like George that are living with chronic and life-threatening illnesses every day have a whole vast array of affordability challenges outside of the cost of just a pharmaceutical therapeutic. I mean, you heard him talk about his premium costs, and he didn't even address things like all the living costs that he has on top of it. I mean, he just really talked about co-pays and lab tests and, you know, doctor's visits. And those things add up. So, you know, I think one thing that collectively we're beginning to gather information around is what that picture of patient need looks like in the future. And I think while the $2,000 out-of-pocket cost is a huge opportunity for so many patients in terms of affordability, that it really does just scratch the surface, and that there will be a continued need for patient assistance programs, whether they be manufacturer or independent copay foundations, that this need will continue to exist. And you know, as I said earlier, PAN will do our best to stay at the forefront of this in terms of understanding and analyzing what that impact is on patient need. We have polls in the plans. We have some additional research that's underway and in the process of being sort of thought through to really continue to build upon this narrative so that this industry as a whole can really stay abreast of what the research is showing and what the analytics are telling us, which I think is the best we can do. Given the environment that we're in, which is CMS still has a lot of decisions to make, and there's still a lot of uncertainty around this act. So we do want to take the rest of the time to open it up to questions because, like I said, I know many of you don't get interactions with patients a lot. We have George here, and then Kelly just knows an incredible amount about not only this reform, but she has dug deep into data, and you saw a few slides. We have a few hundred in terms of the real analytics and what this means in terms of the impact on the patient. So do we have any questions, either virtually or in the room?
Stunned silence.
I know. Did we answer everything you had on your mind? Okay, we have one over here. They're bringing the mic to you, just so we can make sure. I think the live stream wants to be able to hear as well.
Yeah, hi, thank you. Thank you very much for your story and patient insights, very valuable. Hopefully this won't be too far off subject, but it does get back to this notion of reducing patient cost burden. And for Avalere, Has the talk about doing away with the rebate safe harbor completely gone away? And could it still exist kind of in harmony or in addition to the IRA?
Yeah, I think that's a really good question. I think no idea in policy truly goes away. We just put it sort of on the back shelf for a little while to collect some dust, and then someone will pull it out again at some point. So I would not call that a done deal at this point, but I have not heard talks of it coming back soon. Yeah.
All right, any other questions in the room? I find it very hard to believe we answered all of your questions about the impact on patients. Well, we are going to be around, and we'll be at lunch by all means. If you have additional questions, we'll also stick around here for a little while. If you have some additional questions, we're happy to answer those. And we really appreciate your time today. And as I said, we will do our best to keep all of you updated as well through our hub that is now launched on our website. You can just access that for the latest information that we have around the impacts on patients as the IRA goes into.
And Kevin, since we had a couple of minutes, I wanted to add something. So,
of course,
on the Inflation Reduction Act, as a patient, I saw it. I said, okay, $2,000. Well, I was a businessman for, like I said, over 40 years. I analyzed people's businesses as it related to their IT needs and so forth. And I'm thinking, okay, so you're going to take this money that's like this, and you're going to go do this. How does that, what happens to it? Where does it come from, right? In businesses, if I took 80% of your revenue away, something's going to change. So as a patient, I'm thinking, okay, are they going to take the drugs that I need, the drugs that I need for my quality of life, and are they going to move them from what Medicare calls their formulary list to a formulary exclusion? I have drugs that are excluded from Medicare. They don't pay for them, they don't cover them. I pay the total cost of those drugs out of pocket. So I'm wondering if they're going to take the drugs that I use and need and move those from one list over to the other list. I wonder if they're going to change they talk about changing the prices of drugs, whether my drug will be, the price of my drug will increase over time. Will it increase before the act is enacted in 2025? So as a patient, I heard some things today that sounded very good, but as a patient, I want to understand all of that, not just what happens on January of 2025, but what happens between now and then, because all of that's going to impact me. When I hear a 6% increase on premium, that's a lot of money, okay? It's a lot of money. It is, if you're on a fixed income, my fixed income's not going up 6% a year, okay? So it's a lot of money. So any type of transparency around the act, what it really means. I've heard about lawsuits. I've heard about some possible political changes or maneuvering. So as a patient, well, check back with me in June of 2025, and I'll let you know what it really means. That's the patient perspective.
Thank you, George.
Thank you.